using ESR on CRP, and we can interpret this -28 score into how the patient is responding. So there are other scores like Simplified Disease Activity Score or SDI, and the American College of Rheumatology, they propose that we should use this disease activity score, the CDI, and routine assessment of patient index data for patient monitoring. Role of anti-carbamylated antibodies. So in many cases, this is something new that has come up. These anti-carbamylated antibodies, they are not routinely measured, but their presence can aid in diagnosis of RA, particularly in patients which are seronegative, that is negative for RF or ACPA. Other emerging biomarkers are the 14-3-3 eta protein, matrix metalloproteinases, HLA genetic markers, biomarkers like HLA-DRB1, PTPN22, cytokines. So all these can be measured actually, but they are not usually measured routinely for clinical studies. But these emerging biomarkers are the potential, carry the potential of targeted therapy. Imaging modalities other than X-rays, MRI is the gold standard, but USG also picks up the early signs of synovitis, early erosions, and soft tissue involvement with good concordance with MRI. And they are more readily available and cheaper than MRI. Now coming on to the second case scenario, 45-year-old female presenting with fatigue, skin rash, oral ulcers, Raynaud's phenomenon, joint pain, swelling, morning stiffness. So there is, as you can see, the physical examination also shows rash, oral ulcers, skin changes. Investigations show rise in rheumatoid factor, anti-CCP, ANA, anti-dsDNA. So this is a case in which the patient has a combined disease. So we call it a rheumatoid arthritis, SLE, overlap syndrome, or RUPUS. So it occurs in 0.01% to 2% of all SLE cases. And usually the diagnosis of RA precedes the diagnosis of SLE, but it can be the other way around, or SLE may appear simultaneously along with rheumatoid arthritis. So testing for ANA, so it is not routinely done in cases of rheumatoid arthritis, though it can be positive in 20 to 30% of the cases. It is more frequently positive in patients with overlap syndrome, and it has been said that RA patients with ANAs may have a high chance of developing SLE, so that needs monitoring. So these are the various symptoms of lupus and RA with overlapping symptoms: low-grade fever, fatigue, joint pain, swelling, inflammation. These are the overlapping symptoms of RA and SLE. So let's come to the case scenario 3. So a 52-year-old male patient with 2-year history of gout in right knee. He was treated with dose of prednisone and colchicine with marked improvement. Allopurinol was started, but it was not well tolerated. The patient presented with persistent pain, swelling in right knee, progressively worsened and become associated with stiffness. Moderate effusion, warmth, joint line tenderness associated with restriction was seen. No synovitis was appreciated in other joints. The lab tests were also not very much contributory. As you can see, CRP was raised, anti-CCP was raised, RF was normal, and ANA was negative. So if we apply the ACR Euler criteria, the total comes as to 5 points. But the patient went several arthrocentesis, and the review of the slide showed that an inflammatory arthritis was present. Ultrasound also showed joint effusion and synovial hyperemia. The patient was started on methotrexate and showed marked improvement in symptoms. So the patient of rheumatoid arthritis, the take-home message is, they can present with chronic monoarthritis. But whenever there is chronic monoarthritis, we should first consider other diagnoses like tuberculosis, crystal arthropathies, or non-inflammatory monoarthritis. So in those cases, synovial fluid analysis becomes very important to exclude the other causes of arthritis. We should also know about these fibroblast-like synoviocytes. So these are some specialized synoviocytes. So they are called the leader cells. They perpetuate the infection, and now targeted therapy are being devised against these fibroblast-like synoviocytes. So synovial biopsy may also be required, particularly when the diagnosis is unclear, when the patient is treatment resistant, or there is unusual synovial involvement. So in synovial biopsy, what we see are the pannus which is here we can see the hyperplastic synovium and this formation of these tertiary lymphoid organs. And this pannus ultimately leads to cartilage destruction, fibrous ankylosis, ossification, and bony ankylosis. So the RA may coexist with a host of other diseases, autoimmune diseases, Kaplan syndrome, Feltis syndrome, primary biliary cholangitis. So the take-home message is the classification criteria is used for diagnosis of RA, which is basically a clinical diagnosis. No laboratory tests are pathognomonic for RA. Serology helps, but may be negative. The inflammatory markers are helpful in monitoring of the patients. RA may present with atypical features like monoarthritis, so the degree of suspicion should be high. Overlap syndromes may create confusion, and other tests like ANA, ANCA, synovial fluid analysis, synovial biopsy may be required in few of the cases, and these emerging new biomarkers may lead ultimately to the development of personalized therapy. Thank you for your patient listening. And I also take this opportunity to invite you all to our state cytology conference, which is being organized by the Department of Pathology in AIIMS Kalyani, 24th and 25th August. So we will be welcoming you all there. Thank you.
Thank you, Dr. Indranil, for a very nice presentation. I just wanted to know one thing, like you mentioned reactive arthritis.
Yes.
And reactive arthritis, I think you also mentioned it is related to GIT or gut.
Yeah.
Like what are the conditions in which we can suspect that it is because of gut, that reactive arthritis?
So usually, madam, there is symptoms or signs for infection. So,
Okay.
so that is one clue actually.
Any particular gut infection like IBD, IBS, something more in detail?
No, IBD has a different pathogenesis mechanism. It's again an autoimmune basis,
yes.
but this is infection related.
Oh.
So this is basically due to molecular mimicry that there is activation.
Okay, it is by exclusion, you mean to say? Yes. Thank you. Any questions from audience?
My question is, since you said there's osteopenia,
Yes, ma'am.
and mostly involving the small joints as well as the hip and shoulder joints, is there a possibility of osteopenia involving the vertebrates, so resulting in the disc desiccation or pressure on the discs? Is there cases of rheumatoid arthritis having osteopenia and involving the vertebral joints?
Actually, this rheumatoid arthritis usually affects the small joints. What you have mentioned rightly, madam, because there we are constantly moving these small joints. There is also overuse as well as microstroma. So this rheumatoid arthritis, so these are the sites for inflammation. And the amount of synovium in these small joints also is very high. And there is less amount of joint fluid. So all these factors, they ultimately lead to the affection of these small joints. And osteopenia, and if you see the pathomechanism, there is formation of various cytokines like rankle. So there is elaboration of osteoclasts as well as matrix metalloproteinases. So all these ultimately results in osteopenia. Destruction of the cartilage and osteopenia, particularly around the joints, periarticular joints.
I was asking about the vertebrae. Does it also involve the vertebrae?
No, not usually. It's not unusual. But it can present with a variety of symptoms. And these monoarthritis patients, initially they present with monoarthritis, but gradually the other joints get involved.
Thank you, Dr. Indranil. I request Dr. Poonam and Dr. Jyoti to please felicitate Dr. Chakraborty.
Sir, what is the gold standard investigation for RAP and anti-CCP? Gold standard method for RAP and anti-CCP.
So,
usually we do RAP by
ELISA.
immunoturbidimetry or nephelometry.
No, ELISA also can be done.
ELISA. And but what is the
And
gold
I
standard?
think my biochemist friends will be better commenting on that. But I think ECLAB can also detect.
And what is the gold standard for anti-CCP?
Hello?
What is the gold standard
Same,
method
same,
for?
same.
But among, in between ELISA and nuclear, which is better?
ELISA and
In between ELISA and nuclear, which is better?
CLIA is always better.
Thank you, sir.
Thank you, Dr. Chakraborty. I now request Dr. Biman Saikia to please grace the stage to give us his talk on transplant and immunology.
So, good afternoon. So, we divert here a little bit from autoimmunity. And the topic that I have been given is transplant and immunology. I've slightly modified the title of the talk. And since essentially I'll be talking, when I'm talking of immunology of transplant, I will be talking of the immunology of rejection. So, I've titled it as immunology of transplant rejection. So, I'll basically be talking about solid organ transplant, so that is the renal transplantation. So this basically is a topic on that. So like the autoimmune disorders, even the transplant immunology and the immune rejection is immune-mediated process. And everything boils down to inflammation. So that is the end point. Even in autoimmunity, it's ultimately the inflammation and the cascade of inflammation and the molecules involved therein, which ultimately play havoc. And similar to the autoimmunity, the complexity of transplantation is also the price we pay for having a highly effective immune response, which is basically designed to fight against pathogens, but since it is so effective, it also fights and damages our own tissue. So this is the price we pay. But unlike the other immune-mediated diseases like autoimmunity, the transplant rejection is predictable because the disease or the process starts after we put the graft. So we know that this immunological process is now going to start. So because we induce it ourselves. There have been a lot of advances in understanding of the immunology of transplant rejection in the recent years, but some of the basic facts still remain unanswered. And for example, now we know the antigens which are involved in recognition of the graft is the majority. The main component is HLA antigens, the major histocompatibility. But there are a lot of other minor antigens which we actually don't fully understand. So what are the exact immunogenic peptides and other antigenic system that we don't know. And we also do not fully understand, though to a large extent we do not fully understand the effector immune mechanisms and the individual differences, why two different individuals would react differently. So what are these individual differences that ultimately decide the fate of a graft, we do not understand. So the bottom line is that allograft rejection in the transplant field still occurs frequently, and it's a significant reason for treatment costs. Now, when you put a transplant or a graft into a, I need a pointer, just a minute. Okay. So the graft is basically recognized through two different mechanisms. There's the direct allorecognition and the indirect. In the direct, it's basically the dendritic cells and the antigen-presenting cells from the graft itself, which is directly presenting the donor peptides to the recipient T lymphocytes and getting them activated, whereas in the indirect method of presentations, it is the recipient's antigen-presenting cells and dendritic cells which take up the graft antigens, process them, and present it to the recipient's T cells. So this is the major mechanism, because in a graft, the graft dendritic cells will gradually die off, and this takes place in the initial part, but later on the indirect antigen presentation is the major pathway whereby the recipient would recognize the graft as foreign. So when you talk of rejection, there are hyperacute rejections, acute rejections, and chronic rejections. Hyperacute rejection occurs because of a pre-sensitized state whereby there are already antibodies against the graft there in the pre-existing antibodies. So this will lead to an immediate rejection of the graft. In the operation table itself, the graft would turn dusky, there will be thrombosis, and the graft will be destroyed. So this is hyperacute rejection, and this is what we prevent this by doing the cross-match. A cross-match, tissue cross-match, similar to what you do in the blood bank, the ABO cross-match. So this, by looking at the presence of pre-existing antibodies by cross-matching, we avoid this. So hyperacute rejection, with the kind of technology that we have for cross-matching and antibody screening, hyperacute rejection does not occur these days. What occurs is the acute rejection, which can be either cell-mediated or antibody-mediated, and the chronic rejection. So hyperacute rejection, I've already told you. Antibody-mediated, acute antibody-mediated rejection, basically, I'm sure there are some in the audience, there are people who are looking at transplant biopsies to diagnose rejection. So ABMR is basically antibody-mediated, where there will be thrombi in the glomerular capillaries, there will be glomerulitis, peritubular capillaritis, and peritubular capillary linear staining for C4D, which is the complement component. Then you have acute T-cell mediated rejection, where there will be tubulitis and lymphocytes infiltrating the tubules. And of course, the chronic rejection, this is basically vascular. There will be a lot of tubular atrophy, vascular fibrosis, and intimal thickening. So I'm not going to go into details of this. Antibody-mediated rejection is a very important, and lately we have realized this antibody rejection and mediated rejection is one of the major component of rejection seen in biopsies. And we understand a lot more now about the antibody-mediated rejection. There are certain problem areas in the field of transplantation. First is early diagnosis of rejection. This is one very crucial thing. Optimal therapy, ever-growing organ shortage, allosensitization, and transmission and recurrence of the original disease. So these are some problem areas in the field of transplantation. But more than 95% of the renal allografts now, with the modern therapy and modern understanding, will now survive, more than 95% in at least the first year, compared to a 70% survival which was seen in 1990. The reality, the allograft failure is still seen, and the long-term deficiency, that is chronic rejection, it still remains the same. Ultimately, 30% of the grafts will still undergo chronic rejection, and despite all the advantages and advances, that has remained unchanged, the incidence of chronic rejection. So to avoid this rejection, we do the HLA typing, we have different methods, we have the SSP, SSOP. I'm not going into details of this. We have the sequence-based typing, we have the Luminex-based, bead-based typing, and more recently, the epitope mapping that is done to classify the diversity and match the recipient and the donor. And we have other methods, all the methods of antibody screening, whereby you will look at the presence of the donor-specific antibodies in the recipient. We have the flow cytometric methods, we have Luminex-based, bead-based methods, and of course the virtual cross-match, where actually you're not looking the cross-match in the laboratory, but what you're doing is you're looking at the antibody present in the panel of donor-specific antibodies which are present in the recipient and the donor's HLA type, and trying to match these two virtually. So that's a virtual cross-match. So for typing, we have the SSP. This is the SSP technique where this is the plate. These are the wells will have the primers. So since it's a sequence-specific priming, there are primers there. You put the sample, you look at where the reactions are, and then type the individual. Or you can do a SSOP. This is a probe-based technique. So this is the SSOP method for typing. Then antibody screening, we have different methods of antibody screening. The most convenient is the CDC, or the complement-dependent cytotoxicity assay that we do. And this basically depends on the principle that if you have donor-specific antibodies in the serum of the recipient, they will bind to the donor lymphocytes, and when you add complement to this, it will cause lysis of the cell. So we're basically looking at lysis of the cell when you're incubating the donor cell with the recipient serum. So this is complement-mediated cytotoxicity. This is a slide. This is a negative reaction where you can see that lymphocytes are alive and shining. This is negative, and this is where you see that the CDC is positive. All these lymphocytes are dead. So this is a positive reaction that you see in the complement-dependent cytotoxicity assay. So there are other assays that are available. For example, the bead-based Luminex assays are available to look screen for antibodies. We have ELISA-based assays. These are the solid phase assays. And the cell-based assays, as I said, the CDC cross-match and the flow cytometry cross-match. So these are some of the techniques that are available. Can I have some water, please? So these are the techniques that are available with us for antibody screening. So the aim basically is to stratify the risk of the recipient. So if you have a T-cell cross-match positive, or the HLA-DSA, which is more than 5,000, which is a strong positive. So if you have this kind of a situation where we're screening the recipient and the donor pair, then this is high risk, or you have a risk, intermediate risk, or a low risk. So this is to stratify whether to go ahead. If it is a high risk, you don't go ahead with the transplant. If it is a low risk, you go ahead. If it's intermediate risk, maybe you have to modify the immunosuppression and still go ahead with the transplant. So this is that risk stratification that you do by typing in all the antibody screening methods, ultimately to decide whether to go ahead with the transplant or not. Now you have done the transplant. So how do you predict the outcome? How is that graft going to behave? So predicting outcomes and the early detection of rejection is very crucial after the transplant. So the available parameters that we have for diagnosis are the clinical presentation, and the biochemical parameters like the serum creatinine. Now, serum creatinine is a very late marker. By the time the serum creatinine has gone up, significant damage has already happened to the graft. So this is not a good marker because it's a very late and it's non-specific. Though we depend on the serum creatinine to diagnose rejection, but of course, obviously, it's not the right marker. And then the biopsy. Biopsy is still the gold standard for diagnosing rejection. But we have to understand that by the time you go and do a biopsy and demonstrate rejection, the graft has already undergone significant damage, which is irreversible. So we need, this gold standard is basically not the gold standard, because it's a very late, it's a reactive approach. When you see the creatinine going up, then you do a biopsy, then you diagnose, the patient has already gone downhill. So we need biomarkers which are better in predicting acute rejection, and that's the reason why a lot of people have, because even in histology will have its limitations, because the first thing is the reproducibility of the, though we have the regularly updated BAMF criteria that are applied to diagnose a rejection biopsy, but the findings are not reproducible. And morphological diagnosis basically oversimplifies the complexity that is there in the graft injury, because there are a lot of graft injury that is not that cannot be visualized. So there's so much happening at the molecular level, at the cellular level. What you see in histology is the end point. So this is not the right, the histology is not cannot be the gold standard. And the inter-observer variation, if you see in one of these studies in 2013 by Rees et al., you've seen that when there were 3 pathologists looking at a biopsy, when one of the pathologists is diagnosing a T-cell mediated rejection, the other agreed only in 45% of the cases. And all the 3 agreed on a biopsy only in 16%. So the inter-observer variation among pathologists to diagnose whether there is a rejection or not is also a problem. So people have tried to find other biomarkers of rejection, like the molecular markers. There are a lot of studies which are trying to look at molecular markers, CXL10, CXL13, all these, and all to microRNAs. So, but still now there are no definite biomarkers or molecular markers which can actually diagnose rejection. And it is fascinating, but it's actually when you come to clinical application of all the panels of biomarkers and molecular markers that have been shown, it's actually frustrating. So we, in our study, in our lab, we try to take a different strategy of, because people are looking into the molecular markers in the peripheral blood of the recipients. What we try to do in the laboratory, we try to design an in vitro model of transplant, whereby we take the graft biopsy during transplantation, and we have the recipient's macrophages which are already isolated, and expose these macrophages of the recipient to the graft antigen, and then co-culture these already pulsed, antigen-pulsed macrophages with the lymphocytes of the recipient, and look at the gene expression profiles. And we looked at 86 gene profiles. This is basically the inflammatory genes. We looked at these gene profile in 100 recipients, and we saw that the gene expression profiles in different groups like ACR, AMR, and antibody-mediated rejection, and the stable allografts, there are differences, and you can see that a lot of genes in the patients who have undergone rejection are different from the stable allografts. And you can see that the heat maps are also, these are the stable allografts. You see that the gene expression is not very high, but in patients who have undergone rejection, using that in vitro model, it is not actual rejection, but this is in vitro kind of a signature of rejection. So this, you can see that there's a lot of difference in gene expression profiles in patients who have undergone rejection and compared to those who have not. And here, the same kind of a situation here. You can see the difference in the heat maps here and the gene expression profiles. So we concluded from this study, this in vitro study, which is basically designed to predict a rejection, could see that there are genes which can actually predict rejection versus a non-reject patient who would remain stable. People also have, now all this is invasive. You have to do a biopsy, it's invasive. So people also, I'll just take another 2 minutes maybe. People also have tried to look at biomarkers in more simple samples like the urine. If you look at the urinary biomarkers and gene expression profiles in the urine, that also could, and that is a totally non-invasive technique. So if you can find some biomarker in the urine, nothing like it. And people have shown that genes like CXL9, CXL10, these are good biomarkers in urine, and they have seen that patients who actually reject, their urinary levels of these cytokines are high. So we designed another study. Now, when you take the urine sample, the bioavailability and the cytokines, they are very labile molecules. So in the urine, they tend to degrade, and it's very difficult to study the gene profiles in the urine samples because of the very nature of the sample. The urine sample, everything tends to degrade. So what we try to do is we try to collect the urine sample intraoperatively. Now when you're doing the transplant, when you open the clamp and revascularize the graft, it immediately starts forming urine. Even in the operation theater, it immediately forms urine. So what we did, we collected those first few drops of urine intraoperatively, and because so that it doesn't, everything, whatever is there, it doesn't degrade. So we took that first flush urine sample intraoperatively in 200 recipients and looked at gene profiles of all these molecules. CXCL 9, 10, 11, they're already shown to be very good biomarkers in various studies. So we included this gene panel and looked at this gene panel in 200 renal transplant patients. And again, we saw that CXL9, CXL10, 11, interferon gamma, CCL3, these could differentiate patients who had undergone rejection versus those who did not get a rejection. So even looking at biomarkers in the urine itself and utilizing a sample which actually allows you to preserve those molecules when you took this kind of a first flush urine sample. So there we could demonstrate that these profiles, and we employed machine learning to our data set, and we saw that even applying machine learning tools, we could predict that this patient is going to reject and this will be stable. So these kind of studies are still going on, and so these are the indications from this study that CXL 9, 10, 11 and interferon gamma, they can be good markers, and if we can utilize this kind of a sample but this obviously, this is a very initial study. We need to validate in a bigger sample and do bigger studies. So currently we are also trying to, utilizing the same in vitro model, we are trying to predict ABMR. Whether we are trying to, from this model, we're now trying to isolate the B cells and see whether these B cells, after they are exposed to after they are co-cultured with the recipient, with the donor's antigen, whether they are going to produce donor-specific antibodies in vitro. So this search goes on, and thank you very much for your patient replies.
Thank you very much, Dr. Saikia, for a very concise talk on a very elaborate topic and for touching all the important points. Thank you very much once again. And any questions, please?
Any questions? Thank you. Thank you so much.
Thank you.
I request Jyoti Madam to give a certificate of appreciation to Sir. Sir, please, 1 second, Sir. Thank you. Our next speaker. Thank you so much, Sir. We shall have Sir again on the stage as a panelist for our panel discussion next. But before that, we have Dr. Indranil Basu, who will represent a supporting partner, TransAsia. Dr. Indranil, please come.
Hello. Okay. Good afternoon, everyone. With due permission from the chairpersons, madam, I'm starting my presentation. The topic of my presentation is the evolution of the immunoassay testing. We have been discussing about the autoimmunity and all the various detection techniques. So this is a very basic one where we will be discussing the basic antigen-antibody reaction and its detection. Like, all the immunoassays are based on this particular fact of antigen-antibody reaction and how it is being detected by different technologies and how we can increase the sensitivity. And on that very basis, this whole immunoassay is based on. The measurements, the analytes that we measure in case of this particular immunoassay technique can be the hormones like TSH, FSH, cortisol, vitamins, cancer markers, peptides, therapeutic drug monitoring, infectious serology. And the first to come in this line was the radio immunoassay, where we get to see that to the antigen antibody complex there is a radio label, and after several washing techniques and all, with the help of radioactive Geiger-Müller counter, we used to find the radioactivity in the residual sample to quantitatively estimate the analyte. So that was the initial days in 1960s that came, and it came with a lot of shortcomings, like the safety concern to the laboratory personnel. The disposal was an issue. The requirement of building specific laboratory facilities for the thing, and obviously the expense that came into being. So the next in the line that came was the ELISA, that is the enzyme-linked immunosorbent assay. And as you know, to this antigen-antibody complex, we could able to tag the enzyme molecule using different reagents, like glutaraldehyde being one of them. So it leads to enzymatic reaction, which leads the substrate being formed into a product, and the color of the product is directly proportional to the concentration, or inversely proportional, which is based on what type of assay we are choosing. So that came into being. The next was the chemiluminescence immunoassays, or the CLIA, where the detection method was based on the light generated by certain molecules. Like in this particular thing, you get to see that the detection is being done by luminol. It could be acridinium esters, and there are a couple of detectors which are being used, and a light is emitted which is proportional to the concentration of the analyte that is being present. So now came to these immunoassays, there came the different level of sensitivities has been increased by introducing different types of assays, like the direct and the indirect assays. Like in case of the direct assays, you get to see that to the primary antibody, the label is there, the enzyme label or the light label which is attached, leads to analyzing the particular concentration. But more specific it becomes when it is associated with a secondary label, so that is the anti-human globulin. In the next, you can get to see that here it is a one-step reaction. It's a but the indirect one being a two-step reaction, the label is associated to the secondary antibody. So it becomes a next step reaction, and it increases the sensitivity. Enhancement of the antibody detection, antigen-antibody reaction detection, is also enhanced by the presence of like sandwich assay. Here we get to see that the target analyte is being sandwiched between two antibodies, and it increases the specificity of binding to the particular analyte, and finally the detection happens. The competitive assay, here we get to see that the target analyte competes with the labeled antibody, and based on this particular reaction, the antigen-antibody reaction is detected. And in case of a competitive assay, unlike the other one, it's a decreasing curve, because if my analyte, which is less in quantity in a particular sample, then the binding of the labeled antibody happens more to this particular system, leading to a more concentration of the antigen detection at the initial level, and followed by with increase of concentration, the detection gradually falls. So it's a decreasing curve, and this also helps in some assays which we use in our regular immunoassays, like FT4 assays. Coming to heterogeneous and homogeneous immunoassays, like in case of heterogeneous immunoassays, it was a multi-step analysis where we have to retrieve from the bound form the particular analyte and go ahead for detecting it. But in case of the homogeneous assays, we can continue the detection including the bound form. So as we know from our knowledge of organic chemistry, if we reduce the number of steps, the yield is more and the detection is more. So the homogeneous immunoassays helps to increase the sensitivity in antigen antibody detection. Regarding this generation of individual analytes, the kits have been developed in subsequent years, like the first generation, second generation. For example, I have taken the example of this TSH kit, where we get to see that with subsequent generation, the sensitivity increases 10 times. Like here, the first generation was used to detect like lower concentration, like 1 to 2 micro international units per ml. In second generation, 0.1 to 0.2, in third generation, 0.01, and so on, so forth, till fourth generation is there. Regarding infectious serology, we get to see that there are, again, the sensitivity has been increased, and over this generation from 1985 having the first generation, and at present we are using the fourth generation immunoassay, where we get a single result involving both antigen and antibody